Patients with horseshoe kidneys, pose a lot of, interesting differences than most patients. And I'd start to say that also the approach to managing these folks has evolved over time. The patient is a 68-year-old male with recurrent urinary tract infections, and on CT scan we identified 2 to 3 centimeter stone in a horseshoe kidney. The irony is you can live 60 years and not even know you have this. But first of all, it's about 1 in 400, so it's not that rare. Horseshoe kidneys are also associated with UPJ obstruction in about 10% of cases. So there are contiguous anomalies or associated anomalies with this. Originally, we did view horseshoe kidneys or stones in horseshoe kidneys as patients who needed PCNL because the horseshoe kidney is dependent and the stones are in a dependent location. So, you really couldn't remove these stones, either retrograde or with shockwave. That being said, there are a number of studies supporting the use of shockwave lithotripsy in these folks, and while you could carry it out, there was typically residual stone. So I think the sort of expert opinion is that you would do a percutaneous stone removal, and in this individual, that's what we chose to do. Anatomically, a horseshoe kidney, they are lower in the abdomen and more anterior in the body. So when you approach this, we would do this in a prone position. The lung and so on are further away of the pleura, and as such, an upper pole access is the approach. So we have a longer distance to traverse, so we have a long, rigid nephroscope. So that extra distance allows us to get to every stone and every calyx. Ultrasonic energy is typically preferred for the bigger stones because you can fragment and suction the stone fragments with one device. On the other hand, sometimes the distance is quite long, so we would use a flexible nephroscope. And if I'm doing that, I would typically just use a laser to break up the stone and then suction and remove the fragments. This patient did extremely well. He went home the next day. He just had an indwelling stent. And then a number of years later, he presented with a recurrent stone. This is not unexpected, and at that phase, the stone was only 7 millimeters, but he was getting symptoms. He had also, now is an even older gentleman and perhaps less of a good surgical patient, so we discussed the option of ureteroscopy for this retained fragment, even though the angulation, was challenging. While my belief was shockwave lithotripsy wouldn't clear him because the calyces, are too dependent, we have a lot of tools that we can use in endourology today. The endoscopes are better. In addition, the basket technology is better. I tend to not use sheaths as much because of my concerns about potentially damaging the ureter. So our approach is, at this stage, I would place a wire so that we could put the scope into the kidney if we were doing a renal ureteroscopy. The sensor guide wire is the wire we use. And the reason I use it is it's the best combination of all the attributes of a guide wire that you could want. It's a little stiffer, it has a very flexible adaptive tip. At that point, I would take the wire out of the ureteroscope and then proceed to do the procedure. And at the conclusion of the procedure, if we're going to place a stent, then I would replace the wire through the scope. So really, the safety wire is the ureteroscope because you have the scope in the kidney. And the x-rays indicate that when you look at this kidney, you would think there's no way you can do anything but just look at this stone. And in point of fact, that's true. As you know, as good as the laser fibers are today, they still limit the amount you can deflect any scope. So at this level, what's different is a basket is actually more flexible than a laser fiber. And while many urologists might believe this, you really don't understand how well you can use a basket till you start using it in the kidney. So So we're able to look and basket something at a really obtuse location and then bring the stone into a better location to fragment and then subsequently remove these fragments. We would use a tipless basket for this, and tipless baskets are designed to actually function in the kidney. So a lot of people don't know that. So a tipless basket allows a basket to drop into the calyx so that you can grasp it and remove the stone, whereas the tipped basket really is designed for the ureter. The resolution for our patient is he's doing great. And at this stage, we follow him on an interval basis for recurrent symptoms and for recurrent stones. And the last thing I'd say about it is, since the calyces are dependent, if you have a small stone in a horseshoe kidney, if it's asymptomatic, you don't have to treat it. You remember that this patient had infections and had symptoms, and I would make the case, if someone has an asymptomatic stone in a horseshoe kidney, this is a case for metabolic management and follow-up to make sure this stone isn't growing or creating symptoms. But there's no need to immediately treat asymptomatic stones.